Dear colleagues, dear friends, hi. I'm really excited to be here with you today for this exceptional webinar. I'm so excited to do it. I remember it just remembered me the time of COVID when we used to communicate with each other only online. However, I think everybody knows my position about it. I'm not a kind of webinar guy, but however, I think also it has many advantages, such as we can spread it to as many people as we can. But in general, I prefer to see people in front and to discuss and connect. However, I will try to do my best for this exclusive webinar that will be about Gummy Smiles, an innovative solution, mainly the blending of Gummy Smile with Pitts21 system, blending, sorry, of extraradicularis mini screws and Pitts21 system to get awesome result. So, as usual, I will start by just a small introduction about myself. So, I'm Dr. Wassim Bouzid. I'm an orthodontist and I'm also the vice president of the Algerian Society of Orthodontics. So, here is my email if you need anything about or any information about PITS21 system or Gummy Smiles treatment or anything related with PITS protocol, feel free to reach out. I'm from Constantine, Algeria, as you probably know, and I invite every one of you to come to visit me in Constantine. I will be very glad to see you there. So this is my family, my wife Amira and my two sons Fadi and Yanis, and this photo was taken in United States, by the way, in Lake Tahoe. So this was my former clinic. Now I have a new one, and as I have a video, so with it will be a little bit uh, not very convenient to do it as Zoom. So sometimes it's not. Um, um, so the internet is not good. So I'll try to keep you updated about it, maybe if we meet. So always before I start any meeting, I wanna just give some credit about the guys that taught me about orthodontics, and I start with China when I was trained in Wuhan University. So this is my former professor, Dr. Ho Hong. She is actually the president of the Chinese Orthodontic Society. And after that, also I went to Dr. Chris Chan in Taiwan and learned a lot from him and mainly about extraradicular mini screws. And also I'd like to give some credit about Dr. Oh, sorry, return back. So Dr. Florin Kofar from Romania, who is an aesthetic dentist. And I learned a lot about aesthetic dentistry from here. And I'm applying this concept in orthodontics to get the best of both worlds. Also, Dr. John Lin in Japan, Dr. Kondo with Dr. Sabrina Juan, they helped me also a lot to blend the PITS protocol with the occlusal plane control. And of course, last but not least, Dr. Tom Pitts and Dr. Duncan Brown, who are like my spiritual mentors and fathers. I consider them just not like mentors now, but members of the family. And this was 2 years ago in Palm Springs, where I had one of the biggest privilege in my life when I had to share the stage with Dr. Stewart Frost and David Server himself. So, and I had also Tom coming all the way just to see me speaking. So I was really, really, really honored to have all of these famous guys for that meeting. As I said, Tom and Duncan have made both of them a big impact in my life. And not only, because I always try to share this photo, this slide of the GCO, which is the Journal of Clinical Orthodontics, probably the most famous journal in our clinical field, and the most read article ever in this journal is Tom Pitt's article. It means that a lot of people now are interested about the technique, and a lot of people now are just are aware about the potential of what we can get if we are blending the aesthetic principle with Pitts21 system and Pitts protocol mainly. And I invite all of you, by the way, to join this vibrant community, which is the OC Orthodontic Ambassadors. So this is just a slide of with a QR code of our Facebook page, Instagram page, and you'll also find all the links. And you can just join us to have an direct access to education and also to know about the event that the OC Orthodontics is organizing. And I know that I'm convinced that there is no such a better way of involving and learning, such as joining a network like that. So I suggest you strongly to join us, and I promise that you will not regret. So the subject of today is mainly about Gummy Smile. So first of all, when we start to speak about the gummy smiles, we need to know that there are many types of gummy smiles. And I will try to explain briefly what are the difference between these these types. And mainly the diagnosis is really important to know exactly which type of gummy smile we are facing and how we should make the diagnosis and how we should make the treatment plan. So first of all, the gummy smile can be due to a lip problem. And and we will figure out that we are facing a lip problem if we are assessing two things. One is the length of the lip. So basically, the lip length in women should be like 20 millimeters plus or minus 2 millimeters. In men, it should be 22 plus or minus 2, with a 25 to 30% of mobility. Secondly, if if the gummy smile is due mainly to a lip problem, so the treatment plan should be ideally a surgical lip repositioning if you are facing a short lip problem, or most commonly, injection of Botox to get rid of this lip hypermobility, which is the cause most of the time. And see, when we treat the exact etiology, this is what we can get. And second type, so the gummy smile can be also due to a gingival problem. And how to assess that is just by assessing the incisor size. So in general, we have the central incisor should have a size of 11 millimeters in men, 10 in women with this 11 millimeters rule. It means that it's never a good idea to have an central incisor more than 11 millimeter. But more importantly is the ratio. And ideally, the ratio should be situated between 70% to 75%. And I will mainly go to a ratio of 70% if I'm treating a woman and a 75 if I'm treating a man. What does it mean? The lower ratio means longer tooth. So I would strongly recommend to have a little bit longer incisor in women compared to men. And it's really important. The ratio is extremely important. And one of our main objectives, not only in gummy smiles treatment, but in all the treatment, is to restore that ideal ratio. And if we are really facing a gingival problem, so we can have two approaches. First one is the gingivectomy, and second one is surgical crown lengthening. And like the difference between them, so in the second option, we need to remove bone actually. I'm not going into details about this stuff, but usually I'm explaining that very well during our courses because this is a short webinar where I will mainly speak about the third situation of gummy smile. However, this is a case where we had to do a gingivectomy. This is after the healing period. And you can see here the before and after of that patient. So totally life-changing treatment when we didn't only restore the aesthetic, but we restored all the confidence of the patient. Third problem is a problem where we will face a skeletal or dental problem. And here we are mainly speaking about the vertical maxillary access. And usually, how to make the diagnosis about the problem, it's really easy. We need to we need to ask the patient uh, to relax a lot, to relax a bit, sorry, and try to assess the position of the exposure of the upper incisor. If the exposure of the upper incisor is at rest is important, and also the patient when he's smiling is important. So it means that we are really facing a true a vertical maxillary excess. And ideally, any patient should just show 1 to 3 millimeters of gingiva when smiling. So in this kind of situation, so we have to choose between two options. One is the impaction protocol with mini screws, which I will speak about, and second option would be level one osteotomy maxillary impaction. And so surgical, non-surgical, most of the time I choose non-surgical approach because with time and with experience, I think this is the most suitable approach, despite the fact that it can take a long period of time, but most of the patient would agree to have such a beautiful result without surgery, even if they have to wear the appliance for 3 years. But don't you forget that also Gummy Smile can be also the combination of one, two, or three of the first factors. So this is extremely important. And so, however, when we are facing a vertical maxillary excess problem, and this is my subject, so we can have mainly three approaches. If we are in a class 2 configuration, I will do an impaction protocol with 4 mini screws, and I will show you right afterward how we do it in the real life. If we are facing a class 1 relationship and class 1 skeletal relationship, we will make most of the time an impaction with 6 mini screws. And if we have a true vertical maxillary excess with a class 3 pattern, most of the time this patient will be better treated by surgery. So class 1 impaction with 6 mini screws. So this is a case that I had to treat years ago, but this is like a typical case of how we should treat an impact. We should do an impaction protocol with 6 mini screws. So you can see these patients. She is class 1 on both sides. The midline is on. We can see that she doesn't have that much of crowding. However, her chief complaint when she came to see me was mainly her gummy smile. We can see that she's having a big gummy smile, also a tendency toward the deep bite. However, we can also note that her upper incisors are lingually inclined. So basically here with smile arc, as you can see, is more or less nice and curvy. The exposure is definitely not good. This is her chief complaint. The width is very narrow. The incisors are lingually inclined, and we have a microaesthetic problem. So you can see here the DSD, the digital smile design projection. So basically this is where I want to put her teeth. I'm doing just a superimposition for the patient. I'm superimposing the digital smile design template on the patient's mouth just to make her see with her eyes what we are planning to do, what kind of movement we are planning to do with her teeth. And you can have a clear idea about what I've done if you read my orthodontic article about Gummy Smiles treatment. However, this is the treatment plan, so we are planning to do a full arch impaction using 6 stats. So no need to flip the front teeth, despite the fact that this is mainly what we should do in this kind of case. But in this situation, as we had some retroclination of the upper incisor, so we know that when we will do the intrusion of the whole maxilla, our front teeth will have a tendency to flare. So this will be beneficial for us in this situation, but for most of the situation, it's not good as we should counteract this flaring. But as my teeth in this situation were, or my incisor in this situation were retro-inclined, so the flaring is wanted. We want some flaring. So, and I will have to put two posterior IZC mini screws plus two palatal tats also for flaring control. Why? Because if we are planning just to do a full impaction with 4 mini screws, two IZC, two between the laterals and the centrals, what will happen, we will have a flaring of the posterior teeth. And in this situation, what I would strongly recommend to do is to place two IZC mini screws, two 12 millimeters mini screws on the pallet, and basically also intrude the teeth from the pallet. So if you don't know how to put the mini screws, IZC, so this is basically the typical technique. We should palpate the infrazygomatic, the zygomatic process and put the mini screws outside the root. Because when we do it like that, we can easily insert the teeth without interference of interference of any roots. So this is 14 months after treatment. We are using Pitts21 appliance, of course, with SAP bracket positioning. We are putting so two IZCs on the back, two 8 millimeters mini screws on the front, and also we are putting two 12 millimeters mini screws on the pallet. So basically, on the posterior teeth, we are pulling from the outward and we are pulling from the inward, and this is just to prevent any flaring. So this is 14 months of treatment time, and basically what I have to do is just to continue. And this is a comparison, and most of the time, so I know this is not very scientific, but most of the time, as my patient are really, most of the patients that are undergoing this kind of procedure are a little bit stressed about the outcome, and as they see themselves every day in the mirror, so they cannot really see what was the progress of the case. So from every 3 or 4 months, I take photos like that and try to superimpose them according to the bipupillary line and also the two azole of the nose. And here you can see basically the amount of intrusion that we had. I'm continuing the treatment, so this is 20 months of treatment time. And now I'm stopping my anterior intrusion. And what I saw after my aesthetic evaluation is that my smile arc is very, very, very flat. And this is mainly due to the impaction protocol. So take it as a general rule. Whenever we want to do an impaction of the whole maxilla, we will lose our smile arc. So you'd better compensate for that from the very beginning. So if the case requires an SAP bracket positioning only, you should position the bracket into an SAP plus or plus plus, because you are already anticipating about the flattening of the gummy smile. 28 months of treatment time. Here you can see that we enhanced the gummy smile. Why? So what I've done, I just continued my intrusion from the palate, and basically I had clockwise rotation of the maxilla. And now my smile arc is better, as you can see. I have some exposure of the gingiva, but I mean, this is okay for me because I know that I will afterward I will do some gingivectomy on these teeth, so I will have a better ratio of the upper incisors, and my gummy smile that is due in this case to short crowns problem will be resolved. So this is 30 months of treatment time, and you can see now I'm putting my digital smile design template on the patient's mouth, and this is basically, these are the areas where I should do my gingival cuts. So here we go. Photo right after the gingivectomy. So this is before and after, and we can already see the amount of display that we've done for that patient, the amount of reduction of gingival exposure and increase of enamel exposure with this patient. So this is the immediate result, and usually I always, most of the time, ask the patient or I will perform the gingivectomy 1 month and a half after removing the braces, and basically I will ask them also to come back 1 month and a half later to take the final photos. So these are the final photos. As you can see, the gingival is perfectly healed. My midline is on. I have a perfect class 1 molar and canine relationship. As you can see that the lip frame is very nice, and also the rib projection is very nice. And you can also assess here all the aesthetic outcome that we've been able to achieve, such as the smile arc, the exposure, the broad arches, the nice inclination of the upper incisor, as long as the also combined with the microaesthetics. So this is the final Panorex and Ceph. This is the progress 0, 14, 20, 28 to 30, 30 month of treatment time. So this is before and after, as you can see, and the progress of the case. And this is the Panorex and the Ceph, and you can see that we remove the wisdom teeth. So this is non-negotiable for these kind of cases. We should remove the wisdom teeth, because if you don't do it, the impaction of the maxilla will not work. So this is the progress of the case before, during the braces, and after we took the braces off. And this is the final result. Sorry. So this is like a life-changing result for this patient. So why we don't like gummy smiles? Why we find that gummy smiles are not attractive, especially women. They hate that. So this is related to whom? This is my son, my younger son, and I took his photo because I find him cute, of course. But the explanation is here. Why we don't like gummy smiles. And mainly we don't like gummy smiles because of five, or we don't like actually five things in children. We don't like small teeth. We don't like diastemas between the teeth. We don't like monochromatic teeth. We don't like thin lips. And also we don't like the gummy smile. And this is why especially women, they hate gummy smile, because it remember us like it remind us of our childhood, and nobody wants to be like a child, especially if we are between on our 20s to 30s. So this is another case of one. This is one of my first impaction protocol with Gummy Smile, for Gummy Smile. So this was my assistant Sarah, and this I did the alignment, the leveling of the arches, and now all my teeth are more or less in a good position. So I'm putting the mini screws and starting to do my impaction. So same thing, same protocol. So Pitts21 bracket system. Also, I put two IZC, two mini screws between the two 8 millimeters mini screw between the centrals and the laterals, and two mini screws on the palate, and we do the full intrusion. So this is the tracings, and this is the self comparison, and see from the profile picture how she changed. She changed it a lot, and of course true and effective intrusion, and see the amount of gingiva that happened. 28 month of treatment time. The occlusion is tight, very nice. As you can see here, the midline is on, very tight occlusion. The gummy smile disappears, and this is the progress of the case. This is the before and after, and look how we've been able to achieve such big or important arch development for this case. It looks like we've done that with Hyrax or with my Marpi. So nothing of those procedures were undergone, and it was just with using Pitts arch wires. So this is the before and after, as you can see, and see here the before and after, a totally life-changing result, as you can see. Now I'm going to speak about class 2 treatment, about impaction with 4 mini screws, and these cases are mainly done in class 2 patterns. So here is you have Shahinaz, and she's when she came to see me, I think she was 22 or 23 years old. She was student at the university. And when she came to see me, her chief complaint was the excessive proclination of her upper incisors. And as you can see, the full step class 2, the upper arch was really narrow, as most of the class 2. She had a bit of crowding on the lower arch, and also a bit of crowding on the upper arch. I took the Ceph, I took the photos, and from the Ceph and from the profile picture and profile smiling picture, and even from the frontal picture, you can, without doing any cephalometric analysis, you already know that this case would be ideally treated by surgery. like an advancement of the lower mandible because it's so backward positioned. However, as surgery is not an option, the patient said, "No, doctor, I will not go through surgery, but please do as much as you can, and I will be very pleased with the result whenever you feel you'll finish." So I make sure about the agreement with the patient, and I said, "Okay, so I will try to do my best without surgery, but I don't over-promise to them." However, this is my aesthetic assessment. Smile arc is good as for most of the class 2 because of their initial orientation of the occlusal plane. We know that class 2 patients have a tendency to have a steep occlusal plane. The class 1 patient will have a moreover average occlusal plane, and class 3 patient will have a flat occlusal plane. And what I always say, exposure and smile arc are the direct reflection, aesthetic reflection of the initial orientation of occlusal plane. As for class 2 patient, most of the occlusal planes are steep, so the smile arc and the exposure will be good in most of the time. However, in this case, I was doing things in the wrong way. So 5 months of wrong mechanics and wrong diagnosis. So as you can see here, I said, okay, she doesn't want to do surgery. Her upper teeth are a little bit proclined. I will put two IZC mini screw, upright that a bit, and give her some class 2 elastics, and I probably reduce the overjet and she will be fine. However, as you can see, I've created some problems. The teeth are aligned. The upper teeth are now a little bit backward positioned, but the lower teeth are so flat. And more important than that, look at her gummy smile. It was not. I didn't. I was not able to to make the diagnosis of the gummy smile at the beginning. I was wrong because of two things. Because of the real problem himself, I underestimated her gummy smile, and because also she was hiding. And it's not the first time that the patient hides the gummy smile, especially during the first consult, because most of the time these patients are got used to adapt their lifestyle with gummy smiles. So they don't smile that much, so they hide it. And this is what happened to me with that patient. I started to treat her with normal Pitts21 bracket system treatment, just as normal simple case. But after some time, she's like, "Send me this picture," and she's saying, "Look at the gummy smile that I have." And now I have to treat her with the 6 mini screws impaction. And this is actually what happened with this patient. And now, as I said, I have two problems. I have my gummy smile problem, and the second problem is the lower flaring, lower incisors flaring. And the excess of flaring of the lower incisor is probably the worst thing that can happen to you in any orthodontic treatment. Because if you have it, it will be basically impossible for you to achieve an ideal result at the end of the day. Impossible. So whenever you have it, your first goal, your first primary goal should be to operate the lower incisors and give them an ideal torque control. And however, we found that there is no such a better way of doing that, such as the use of reverse rainbows elastics, IPR at the same time, and also class 3 elastics. So this is the perfect combination of operating the lower incisors. And if you combine broad arch wire, also the torquing chain, IPR, with class 3 elastics and reverse rainbow, within 1 to 2 appointment max, you will be able to operate your lower incisors. And now, as we operated the lower incisors, our second step will be the insertion of two 10 millimeters mini screws between the upper laterals and the canines, as you can see. And I will also do an impaction and retraction at the same time, and I will ask her to rear with the reverse rainbow at night just to maintain the lower incisor inclination. So why in this situation we are not using 6 mini screws, but we are just using 4 mini screws, and we don't want and we are not using a mini screw on the pallet? Basically, this is the exact biomechanic explanation, so I want 100% of our concentration now because the things that I will explain are very important. So this is basically our upper arch. We are using here an IZC mini screw, and if we try to assess the force, I know that this IZC mini screw will give me a pullback force that will distalize my upper incisors. And at the same time, of course, this power chain will generate a moment. And this moment will give me an extrusion of the anterior segment of the upper arch and an intrusion of the posterior segment of the uh, intrusion of the posterior segment of the upper arch. And this is what will happen actually. So we will have a counterclockwise rotation of the upper teeth. So on the other hand, if we combine the power chain that we used from the IZC mini screw to a power chain that is used from the upper front tabs between the laterals and the central. So what will happen? So let's just focus on the first power chain, the IZC mini screw power chain. So basically it will give me distalization, the posterior segment will intrude, and the anterior segment will have a tendency to extrude, but it will be counteracted by the intrusion effect of the anterior power chain that is related to the upper mini screws, to upper front mini screws. And what will happen actually, I will have a full intrusion of the upper teeth without using uh, um, uh, palatal mini screws, as we are pulling directly from the IZC mini screws on the upper canine. So we are not just pulling on the arch wire vertically. That's why we didn't have any flaring. 12 months of treatment time, as you can see. I'm asking the patient to wear this reverse rainbow just to maintain the nice inclination of the lower incisors, sorry. And here I'm using my setup, so two power chains from the IZC to the canine, and I'm also using my anterior mini screw for the anterior intrusion. And this is basically the best trick that you will ever get today in this webinar. Whenever you have a case, a skeletal class 2 case that requires some forward positioning of the lower mandible, you need to use this setup. You need to use this setup, and this is the third step, and it's a long elastics from the upper IZC mini screw to the lower canine that will help you achieve an auto rotation of the lower arch. So this is basically the biomechanic of this elastic. So first of all, we are using a power chain from the IZC to the canine, so I will have a pullback force movement that will give me some intrusion of the posterior teeth due to the moment, and the anterior I will have also an intrusion due to the anterior mini screw, to anterior power chain coming from the mini screws. And now my elastics that the patient is wearing from the IZC to the lower canine, what will it give? It will give me some pullback lower incisor force, but more importantly, it will give me a lower occlusal plane counterclockwise rotation, and by doing that, I will have a forward positioning of my chin. So this is basically what will happen if we are considering the face and what we are considering what has been done from a biomechanical perspective. So we are doing first step, a full intrusion of the maxilla, and then second step, give the patient long class 3 elastics from the IZC to the lower canine. It will help them to rotate the lower occlusal plane forward. So this is 20 months of treatment time. You can see now that my midline is on. I have very tight occlusion, and I have nice class 1 molar and canine relationship. And now I'm doing my Gummy Smile evaluation. And basically in this kind of with these kind of problems, I will manage it in two ways arriving at this stage. Either the patient really trusts me and I will just talk to him that I know that the remaining gingiva is just due to some hypertrophy and the ratio is not very good. So at the end of the day, we will do some gingivectomy that will give me the nice ratio. So no need for immediate result now. And some patients, they are not really stressed a bit. not really convinced about what I'm saying. And in this kind of situation, I will do some gingivectomy uh, during the treatment just to show them what we are, what is our projection. So basically, for this case, she was convinced, and I said to her, okay, we will just do a gingivectomy right away after the treatment. So these are my final result. This is the final arch form. This is the final lower arch form, so no crowding remaining. And you can assess here the arch development that we've been able to achieve. Look at the progress of the case, 20 months of treatment time, but I could easily save 3 or 4 months if I had the right approach right from the beginning. And the biggest reward in this case, look at the chain. With this setup, impaction of the maxilla, and using class 3 elastics from the IZC to the lower canine, basically you cannot, it's very hard not to get a good result, because with this biomechanic, the intrusion of the maxilla and also the class 3 elastic from the IZC to the lower canine will give you a counterclockwise of the mandible and bring my chin forward. So basically, this is the finishing stage. I'm doing some minor adjustment, wire bending, etc., giving the patient some elastic just to set the occlusion, taking the final photos. The arch, where the smile arc is good, as you can see. Exposure is nice, and I know that I have to do some gingivectomy, but I'm pretty sure that the post-treatment exposure will be very good. The width was increased, the incisors were upright, and we still have some microaesthetic detailing, mainly due to a laser. So this is before and after. This is before and after, you can see, and this is before and after for that patient. So 27 month of treatment time. Mainly my midline is on. I have very tight occlusion. So I scheduled the patient to do some laser gingivectomy. So this photo was taken just after the gingivectomy. So I always give a patient 1.5 months of rest, of healing period, and ask them to come back afterward. So this is the progress. This is the progress from the other side. This is the final pano and ceph. This is the superimposition. And look at the profile at the end of the day. And this photo was taken just after gingivectomy, as I told you. She came back, I think, 1.5 months or 2 months later. We offer her a free bleaching. You can see that now the occlusion is perfectly tight. The midline is right on the middle. A very tight class 1 canine and molar relationship. The tooth parallelism is very nice. This is the before and after comparison. Look at how wide we've been able to develop the upper and lower arch. And here you can see that I've took just an intraoral scanner just to let you know about how tight we finish it with a very nice occlusion. Most of the time it's very hard to get this type of occlusion, especially if you are treating gummy smiles. So here, as we develop the arches here in a very important way, so I just took CBCT to show you that despite this fact, all my teeth are within the bone. So this is the final result of that patient. You can see that I have a very nice smile arc. My exposure is very nice. My upper teeth are very upright, as you can see. My microaesthetic is very nice. And look at the forward positioning of the chin. So this is like life changing for her. This is like a surgical case with treated without surgery. So for 95% of the people that I showed them this case, they got really mad of how could you do that without surgery? For me, or for 95% of the people, it's like a typical surgical case. So this is the progress before, during, and after the treatment. This is the final photographs, and this is before and after. But look at what amazed me more. She came to see me 1 year afterward. She got confidence onto herself, decided to lose weight, and she now totally totally another person. Look at how her occlusion is stable, perfect class 1 canine and molar relationship. The midline is really straight on. Teeth are very well aligned, very nice inclination of the upper teeth. And see how now her chin is well projected forward. And now she's having this high definition of the mandible angles, and also and all this, the thing that this is like a famous cosmetic procedure when the patient won't have the jawline. She got the nice jawline just with orthodontic treatment. And see, this is before and after, totally life-changing result for that patient. Now let's move also to another case. And this case also, I'm just showing you some step of this case because it was probably is one of my most challenging case. So this is a very severe gummy smile, and also the patient decided not to go to undergo surgery. Though this is 9 months after the initiation of treatment. I like always say during my conferences, like for class 2s or class 3 important skeletal discrepancy, whenever we put the braces on, we have like a skeletal decompensation or dental alveolar decompensation. It's same thing for this gummy smile. I feel like we have a decompensation. And the gummy smile that is appearing at the beginning of the treatment is certainly not the gummy smile that you're gonna get just before starting your intrusion. It will be more important. And this is the actual situation. So we decide now we are so in 1919 stainless steel, and we decide to put 6 mini screws. So two between the laterals and the centrals, two IZC, and two on the palate. And we are doing our full intrusion, 24 months of treatment time. I got some flaring, so I have decided to add some torque, do some IPR, and also pull back my upper teeth. And this is the before and mid treatment. So after, I think, more than 3 years, we decide to take the braces off. And of course, this is the result. Is that an appealing result? Is this what our patient wants after 3 or 4 years of treatment time? Definitely not. So what does it cost me to do to my patient a 5-minute laser and get this awesome result afterward? So basically 3 years of treatment time, and see the result. Midline is perfectly on, very nice very nice interdigitation, and look at the facial change that we got for that patient before and after. So totally life-changing result. So you want to see more? How about this case? And as I said, this is not the true discrepancy. The true discrepancy in reality is this. This is after what I call the decompensation. This is after we see the real gummy smile that the patient will display. And to tell you, this patient was treated just as the previous patient, a combination of Pitts21 bracket system with 6 mini screws. However, if I have to give you some guidelines, always in this kind of procedure, you have to go very slow. You have to go very slow. You have to avoid any risk of root resorption, because you know that this is not physiological movement. With the intrusion is not a physiological movement. That's why you need to be aware and not to push very hard and to push on the limit. So this is very important. Unfortunately, I will not show you the protocol and the treatment planning for this case. Just probably you will see me, we will meet in person, and I will be really happy to show it to you during a conference or an in-person meeting. So, and don't forget that one of our biggest reward in orthodontics is that we are able to change our patient's life. So, of course, I want to thank my staff. I want to thank my patient for believing in me and giving me the opportunity to build the smiles that they deserve at the end of the day. So it was a pleasure to serve you today with this webinar, and I hope that we will get the chance of doing more webinars and to get in touch with each other. And don't forget to, as I said, I will put the slide again. Don't forget to log in our uh, ambassador OC ambassador program. You can scan the QR code and get into in our and join to our Facebook and Instagram group. Don't forget that network is very important. Learning is extremely important, and for me, this is the best possible way to learn and to grow. So let's learn, grow together, and be the best orthodontist in the world. Thank you so much once again for giving me this opportunity and hope to see you very soon. Bye bye.